Okay, so hi everyone, I'm Dr. Shivangi. I'm your dermatology faculty at Medway, and finally your NEET-PG is over. I mean, an exam I think that got postponed like a million times is finally over. Today we're going to do a NEET-PG recall, but I just want to tell you that relax for some time, because if you're getting a seat, again, times are going to be tough. Residency is not a cakewalk. It's going to be very exhausting. And if sadly you have not prepared well and you will have to prepare again, times are going to be tough again. So this is a golden period. Just enjoy this time and just relax and just see whatever you've gotten right, what you've gotten wrong, and we'll just take it from here. Okay? Alright. So see, these questions are not made by me. I have just taken the questions that have come from the students who have given the paper. What I have are a couple of questions. I have around 12 to 13 questions with me. Okay? Also, the exam happened in two batches this time, in the morning and the evening batch. So obviously you will have some questions and some will not be your questions. So don't worry about it. Don't think that, oh my God, I did not solve this question. Must be not from your batch. Okay. Now, let's start with the first question. If you have any queries, you can just, I am checking the chat. If you have any question that, you think is different over here and was different in your paper, you can please write it there. We can discuss it and we can just manage that. All right. So now first question is, a 23-year-old male complains of painful rash. So there is a painful rash . Okay. A 23-year-old male complains of a painful rash in the genital lesion. Okay, it is painful and it is in the genital region, as shown in the image below. So I am sure that this was not the exact image, but this is like a image that can give you a rough idea of what the question could have been. All right. Identify the diagnosis. See. Okay, you are 100% sure that this was the picture. Amazing. All right, great. So see, a 23-year-old male comes with a painful rash near the genital area. Firstly, genital. Secondly, painful. Thirdly, what do you see over here? You see grouped vesicles. Now, when you think of herpes, I've taught it in my class also that herpes will always come in grouped vesicles, be it herpes zoster or be it herpes labialis or be it herpes genitalis, always grouped vesicles. Okay, so that gives one idea that it could be herpes. Secondly, it is a painful rash. Normally, herpes genitalis is not that painful, but herpes zoster, okay, herpes zoster is a painful rash. Their prodromal symptoms, there is first pain and then followed by a grouped vesicles. So it could be herpes zoster. If painful was not given, if just the image was given, it could be herpes genitalis. Okay, but nevertheless the answer is going to be herpes infection, which was clear cut. So I don't think this question was a very difficult question. Looking at the paper, it was a little unusual paper. Generally, NEET is not supposed to be of this level. But it's okay, like you can still make out the answers. You might not be 100% sure while marking them, but you can still by various ways reach a particular answer. Alright, I'm still checking the chat. If anything, please let me know. Alright, so this is herpes infection. Why is it not chancroid? Why is it not syphilis? Why is it not LGV? See, LGV, so you have primary lesion and secondary lesion. Grouped vesicles are not there. Primary stage is there, secondary stage is there. And in syphilis, see, syphilis can be a closed ED, but syphilis, what happens is there's going to be a painless. Syphilis is painless. I've told you that syphilis is very hard, बहुत hard. So it is painless, it does not care. So as soon as you see painful, syphilis goes out of question. Chancroid is painful, but they would have also mentioned lymph nodes, which are also painful, which are not mentioned at all over here. Okay, and you see grouped vesicles, so that goes in the favor of herpes, either herpes zoster or herpes genitalis. Okay, so this was the first question. If you have any queries, if you have any concerns, please let me know about this. Now the second question is, identify the marked structure shown in the diagram. Okay, so see, now what is this? This is your hair. All right, and you have structures attached to the hair. Now this is what they have marked, this thing. Okay, see, a very simple question. If you have read the basics of hair, this question, this image you have definitely seen. Okay, let's start marking everything. Let's start understanding what all is given over here. Firstly, we have, what is this? This is your epidermis. Okay, what are these zigzag lines? These are your DEJ, dermo epidermal junction. Alright, this is the question that they have asked. What is this? This is your dermis. This basic you understand? Okay. Now there is a muscle over here. This looks like a muscle clearly. We know that erector pili is a muscle. So this is erector pili. Okay. What is this? This looks like a gland. We know that with the hair we have sebaceous gland associated. Okay. Why not sweat gland? See, sebaceous gland releases its secretion around the hair, in the hair, so that is why it is perifollicular secretion of sebaceous gland. But sweat gland, it directly releases its secretion on the skin. It is not associated with the hair. Alright. So, if you see a gland associated with hair, the answer is going to be a sebaceous gland. Alright. This is your hair bulb, your hair papilla, everything. This is your sebaceous gland. Any questions? Please let me know. Okay. Alright. The next question, again very straightforward question, you can just see and mark the answer. Now, a 38-year-old patient. Okay, so I've seen this question I've received multiple versions of this question myself, and we are not really sure what was the question. But I will take it from here. If you have other variants of this question, please put it in the comments. I will, help you with whatever you're asking as well. So this is a 38-year-old patient with a hypopigmented anesthetic patch. In dermatology, when you look at hypopigmentation with anesthesia, your first DD has to be leprosy. Nothing else, think of leprosy. Hypopigmented anesthetic patch. It was sent for biopsy. Okay, it was sent for biopsy. Alright, and intradermal antigen testing. Okay. Using the image given below, pick one correct statement regarding the condition. I am not sure if the options and the image is correct over here. I will give you two scenarios wherein two things can be given and two different answers will be there. You just see what was given in the question and you will know your answer. Okay. Taking this scenario first, if this is the image, I can clearly see a granuloma here. Alright, I don't see grain zone or anything, I just see a granuloma. Okay? If this is the condition, if I see a granuloma, what is it going towards? A granuloma goes towards a tuberculoid pole. Okay? So that could be a tuberculoid leprosy, and we know that intradermal antigen testing is positive in the tuberculoid lesions and it is negative in the lepromatous side of the lesions. Okay? So if this is the question, it could be tuberculoid leprosy with positive antigen testing. Some people are saying that granuloma was not present. Alright, and they are saying that instead of granuloma, what we had was grain zone. If that is the condition, grain zone goes towards the lepromatous pole. Okay, and lepromatous pole will have a negative antigen test. So either it is going to be, if it is granuloma over here, it is going to be tuberculoid leprosy with positive antigen testing. If there is no granuloma, it is going to be lepromatous leprosy with negative antigen testing. Okay, the answer has to be one of these depending on what image was given. Okay, I will wait for this question. I can come back to this. If you have any concerns, you can leave it in the chat box and we can just come and see what were your opinions about the question. Alright, the next question is that there is a 25-year-old patient presented with rashes on his palms. Okay, this is important, palms and maybe soles also. I don't know if soles was mentioned or not, and body. So he has lesions on the palms, the soles and the body. Frame a diagnosis using the histological picture given below. Chalo, theek hai. See, one person also told me that there were islands of sparing mentioned. So I have received two variants of this question. If the islands of sparing word is mentioned, that is your biggest clue. Okay, that we have read in the class. If islands of sparing is mentioned, the answer has to be Pityriasis, rubra, pilaris, because that is characteristic of PRP. Okay, keratosis follicularis, no. Psoriasis cutaneous psoriasis it should have been, and T-cell lymphoma. See, the answer is Pityriasis, rubra, pilaris, and I will tell you how exactly the question might have been framed. They would have said that there are lesions on the palms and the soles, lesions on the body with skip lesions, okay, and a histopath may be given. What happens in PRP? It is a follicular keratinization disorder. Okay. Here you have hyperkeratosis on the palms and the soles. That looks like PRP sandal, Pityriasis rubra pilaris sandals. Basically the palms and the soles, they become very thick, and on the body you have orangish lesions that will initially be apart and later on they will kind of close together and they will give you lesions, islands of sparing. So the whole body, whole trunk can be covered. Suppose if this is the trunk, I'll make it here. If suppose this is the trunk, okay. So the whole trunk may be covered with some areas where there is no lesion. This is all red, 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 red. Okay, this is all orange, like this. So you have islands of sparing. I'm waiting. If anything, you can please ask it in the comments as well. Alright, I'll just, so these would be the islands of sparing. There's nothing, no lesions over here. Rest everything becomes red in color. Okay, that is a very characteristic lesion of Pityriasis rubra pilaris. Even if you don't know the histopath, you know that palms are involved, soles are involved, body is involved with islands of sparing. Think of PRP. Alright. Just give me 1 second. I don't think I can see the comments in case they're coming. Okay. Alright, so there have been no comments, fine. Now, the next question is going to be: a patient presents with a nodulo-ulcerative lesion on the lower lip as shown in the image below. Okay, which is the best way to take biopsy in this case? See, in general, when you have a mucosal lesion, when we talk about mucosa, you don't want to play around a lot because it bleeds a lot. Okay, so usually also in mucosa we try to take an excision biopsy, we try to take the entire lesion out. Okay, so in general, just a rule of thumb, just remember that usually we take a excisional biopsy only. If you want to like marofaya tukka, it has to be excisional biopsy. Now let's see, there is a lesion over here. Okay, this is your lesion. Alright, now the options they have given is superficial incision with normal mucosa. Why would you want to do that? Because that will lead to a lot of bleeding. You superficially excise it, you already see that this lesion is a little bluish to purplish in color. There's a lot of blood inside which is going to bleed, so you don't want to play around. Okay, a blush biopsy, there's nothing called as a blush biopsy. I think it could be a punch biopsy or something. Please let me know if something else was mentioned. Now, deep incision with the nodular part or an excisional biopsy. You always try to take an excisional biopsy in cases of mucosal lesions. Another reason why it could be an excisional biopsy is that it is a nodulo-ulcerative lesion. Even if it is a ranula, suppose it's just a plunging ranula, okay, you would still want to take it out completely. Nodulo-ulcerative lesions also can kind of point towards pre-malignancy, okay. So you don't want to leave half the lesion, half the pre-malignant lesion behind, still you want to take it out completely. So definitely the answer has to be excisional biopsy. You want to just completely take it out, okay. Now the next question is a farmer. There's a farmer which itself points toward an answer, like a couple of DDs, with a history of prick injury. Okay, presents with multiple discharging sinuses. There was a history of prick and then he had multiple discharging sinuses. Multiple discharging sinuses in dermatology, what do you think of? You think of mycetoma. Okay, this is something you have to know. During the staining process, filamentous organism was seen. See, now there are two ways to approach this question. Either you have read very, very nicely, or you are just playing smart in the exam. Okay, you just know that multiple discharging sinuses has to be a mycetoma. We have two types of mycetoma. You can either have a eumycetoma or you can have an actinomycetoma. Alright, what is a eumycetoma? It is caused by a fungus. Actinomycetoma is bacterial in origin. So this is fungal and this is bacterial. Okay? fungal and bacterial. Now let's just see what all they have given in the options. Let's see what could be the causative organism. Sporothrix we know does not cause mycetoma. Histoplasmosis also does not cause mycetoma. Nocardia can cause mycetoma. Cutaneous leishmaniasis also does not cause mycetoma. So you don't even have to bang your head with filamentous organism. You can directly go with nocardia. But otherwise we know that nocardia is a bacteria that is a filamentous organism that is going to give you actinomycetoma. Even if you don't know that, the other three options anyway do not cause mycetoma. Okay, so the answer has to be nocardia. Any questions? Alright, now the next question says identify the condition under immunofluorescence pattern using the immunofluorescence pattern shown in the image. This is a 2-second question. You have to see it, you have to mark and you have to move on. What is this? This is your fish net appearance. Okay, this is fish net pattern. Where is it seen? It is seen in Pemphigus vulgaris. Okay, in bullous disorders, we do immunofluorescence and we have different types of patterns. You have to remember these patterns. Fish net pattern, don't you see that like a fisherman's net? Like, the nets to catch fishes. Like that it looks. It is a classical thing that is seen in Pemphigus vulgaris. Alright, you have to know this. Okay, next is a 5-year-old child. Okay, firstly it is very important. If they have mentioned, see, 2 things they can mention in the question. Either where the person is hailing from or the age. Most of the times it is not a useless information. When you read the first line, usually we just are very overwhelmed with the image and we are really excited to see ki aage kya likha hai, let me just complete the question. And we completely ignore the first 2-3 words of the question. 5-year-old child, a very big pointer towards the diagnosis. Okay, presence with a focal area of hair loss. Focal area of hair loss. Now, when you think of child with hair loss, you have very limited options. Okay, what could it be? It could be, firstly, it could be tinea. Usually in tinea capitis, a child comes. Usually, like 99% of the cases, it is a child only. Okay, think of tinea capitis. It could be, it looks like a well circumscribed lesion. It could be alopecia areata also. Okay, can be a child. So, ye 2 DDs, so you have to understand ki if it is a child, it could be tinea capitis, it could be alopecia areata. Now, the image is accompanied by scaling and itching. So, there is a lot of scaling and there is a lot of itching. Scaling now goes in the favor of tinea capitis. Okay? Scaling is not seen in alopecia areata. Even itching is going in the favor of tinea capitis. Alright. There is also a similar history in a sibling 2 years back. Okay, 2 years back, okay, but there is a history in the sibling. So, sibling is also, if the child is 5 years old, mostly the sibling is also a child. So, that sibling who is also a child had the infection. He was able to give it to his sibling who is only 5 years old. What do you think it is? It is a disease that is being transmitted. Alopecia areata is an immunological disorder. Tinea capitis is a fungal infection that gets transmitted. Okay, so the answer over here is straightforward tinea. Alright, what goes in the favor? Child with scaling and itching and hair loss and a similar history in the sibling goes in the favor of tinea. Alopecia areata, you don't need a history in the sibling and anything of that sort. Pyoderma, no, pyoderma will have folliculitis, you will have, discharging sinuses, pus, something like that. Pediculosis capitis, there is no need to have hair loss. You will just have itching on the scalp, you can have occipital lymph node enlarged, okay, but no hair loss in pediculosis capitis, okay. So, this is why the answer is going to be tinea capitis, alright. Next question. Now, a hair shaft is given with arthroconidia is seen in the image below. Identify the fungus associated. So, see, this is what they are showing, maybe this is like the kind of, think of this as a hair shaft. So, whatever is there is inside, okay. We have seen that there is something called as endothrix wherein, and there is something called as ectothrix. Okay, in endothrix you have lesions inside. The conidias, the arthroconidias, they are inside the hair shaft, okay. And in ectothrix they are outside like this. This is arthroconidia outside, okay. So, this is your ecto and this is your endo. Two possibilities. Now, we clearly see that everything is inside. Okay. Identify the fungus. Okay. See, let's rule out. Tinea though, it's a very vague thing because all of them come in the, fungus category. Tinea is a fungus. Now, Tinea, so just keep it aside for now. Epidermophyton, trichophyton and microsporum. We know that trichophyton is the one that involves all the three. Tricho is 3. So, it will involve the hair, the skin and the nail. Okay. Microsporum में N नहीं होता. So, it will not involve the nail. It will involve the skin and the hair. And epidermophyton में hair नहीं होता. It will involve the skin and the nail. Okay. So, this is your situation. So, epidermophyton is out only पहले से बाहर because it does not involve hair in the first place. Okay. Now, you have trichophyton and you have microsporum left. What is the funda? If this is your hair and if this is your hair, how do you make a T and how do you make a M? So, you make a T like this and you make a M like this. So, trichophyton is endo and microsporum is ecto. Here they are asking about endo. So, what is the answer? The answer is trichophyton. Okay. I hope you understand. There's a very easy way to remember this. Trichophyton and microsporum, T goes inside. So, this is endo and M stays outside. So, that is ecto. So, that is why the answer is trichophyton. Any questions? Please let me know. Okay. Now, there's this question wherein they say that a drug is to be given to a 25-year-old male with acne as shown in the image. So, according to this, the acne was on the chest, on the back, on the face. So, this is the face and this is the back, I believe. Okay. So, face and back pe he has acne. What is the drug that you will give? Okay. See, first of all, if it is a back acne, depending on what is the severity. See, I'm not sure if this is the image. If you have given the exam, I'm sure you would remember what was the severity. So, I'm just going to tell you different scenarios and what will be the answer in each scenario. Okay. If there is a nodulocystic acne, if you see nodules, big lesions, okay, and you have cysts, what is the treatment? The treatment is going to be oral isotretinoin. Okay. Oral isotretinoin. If you have minute lesions on the face and on the back, then you can also consider doxycycline, systemic doxycycline. Okay. Topical tretinoin, though, it is out of question. If the acne has already reached, topical tretinoin will only help with comedones, okay, because it will kind of exfoliate the skin. So, only comedones, so not here. You see clear lesions over here. Systemic doxycycline, systemic minocycline, I think that's what they wanted to say, minocycline, and systemic isotretinoin. Depending on what was the image. If the image had big nodules and cyst, a nodulocystic acne, the drug of choice is oral isotretinoin. And if the image had small tiny papules, little pustules here and there, you can also give doxycycline. Okay. So, there could be two answers. If it was thick, big lesions, you go with systemic isotretinoin. If there were small lesions, you can go with systemic doxycycline. But doxycycline and minocycline are more or less the same. So, if you have to rule out, then that way you have to go with systemic isotretinoin, okay? Because doxycycline and minocycline, we both are given for papules and pustules, alright? So, it's very difficult to choose one answer from doxy and mino, and that way if you want to just be like, okay, the examiner is asking me to choose between doxy, mino and isotretinoin, where doxy and mino have similar action and tretinoin has a different action, you should go with isotretinoin, okay? Okay, leprosy wale mein somebody has said something, granuloma tha. Granuloma tha, then it is a tuberculoid leprosy. And if it is a tuberculoid leprosy, then you have a positive test. Let me just go back to the question. If the granuloma is given over here, then it is a tuberculoid leprosy for sure. And we know that TT pole gives you a positive antigen testing and lepromatous pole gives you a negative antigen testing. So, then the answer will be tuberculoid leprosy with positive antigen testing. Okay? Alright? Chalo, if anything else, please let me know. Alright, so next question is a 30-year-old patient. Alright, so there's a 30-year-old patient, comes with a history of flat lesions near the anal canal. Okay, maybe it was anal regional, maybe not canal. Okay, rashes on the body, alright, and hair loss that follows a particular pattern as shown in the image. What is the diagnosis? Okay, so here what is the point that will help you kind of reach the diagnosis? Firstly, it is a 30-year-old male. What does that mean? A sexually active male. History of flat lesions, which are, I think somebody had also mentioned moist lesions, but chalo theek hai, flat lesions around the anal area, okay. Along with that, they have rashes on the body. Along with that, they have a hair loss which looks like this. This looks so much characteristic to a moth-eaten alopecia. Okay. Now, just see, moth-eaten alopecia seen in syphilis. Does syphilis fit in the picture? A sexually active male? Yes. Flat lesions, what could it be? Condyloma lata. These are flat, moist lesions that are seen in the genitals, okay, usually around the anal openings. Near the anal canal, it's mentioned, maybe somebody has just kind of confused it, but near the anus, you will have flat, moist lesions of condyloma lata. And rashes on the body. Of course, you will have rashes on the body because where are we going? We are going towards secondary syphilis. Secondary syphilis has a rash on the body. And a hair loss, again a feature of secondary syphilis. All of these fit in secondary syphilis. What is the diagnosis? Wow, option is also secondary syphilis. So, not even syphilis, they have clearly mentioned secondary syphilis, alright. Why is it not Tinea capitis? You don't need flat lesions which are moist near the anal canal for secondary syphilis, okay. Alright, then alopecia areata and malassezia. Malassezia will cause what? It will cause versicolor, not needed over here. Alopecia areata. See, alopecia areata can also come with these lesions, these lesions. But with alopecia areata, you don't need all of the extra history that has been given. There was hair loss, there was a rash on the body, there were condyloma lata. Clearly, you have to just see the question, you have to clinch the diagnosis of secondary syphilis, mark it and move on. You cannot waste a lot of time in dermat questions which are especially easy, okay. Now, oh, that's it, okay. So, also there was, I think there was one more question which I have seen which was regarding a box shaped lesion that was given, which I have not gotten it as a recall from my sources, but I have seen that there was a question of a box shaped lesion also. I just want to just roughly touch on that question. There what they had mentioned that there was a box shaped lesion and the options, one of the option was morphia. So see, what happens is that morphia has initially induration and later on it has fibrosis. Ho sakta hai that box that they had shown like this could be a fibrotic lesion of morphia, okay. So that one lesion of the box, for now think of it as a fibrotic lesion of morphia, alright. These are all the questions. These were, I wouldn't say they were very difficult, I wouldn't say they were very easy. So clearly with the paper we can understand that we are kind of moving away from mugging up things and we are kind of moving towards understanding things better, okay. So for future approach, if you are planning to give another exam, if you were just an intern and you did not do that well in the paper, just try to understand, don't stop mugging up things now. Try to understand the concept, why is this going in this, it's very easy when you understand the concepts. The questions will happen much faster. Mugging up, you get so confused in the exam, you're just like, iska kya funda tha, isme kya yaad kiya tha, don't go towards that. Try to understand the question, you will secure much better, alright. Thank you so much.